To emphasize something about the clinical appearance and the imaging appearance that are going to help you make a differential diagnosis for white matter disease. And how many of you go to a conference, multidisciplinary conference, and the neurologists ask you, does the patient have MS? Does that happen to you? Does that happen to you? Because I have the same answer. Every time they say, does the MR show MS? I say, what did the LP show? Because for some reason, they don't want to do a lumbar puncture. They expect that magically the imaging is going to make the diagnosis for them. So one of the things I learned is stealing from one author is plagiarism, but stealing from everyone is research. So I've had a lot of help again, putting this together, especially from a number of neuropathologists. So we're going to talk about tumefactive demyelination because that's critical that patients don't get that biopsy. So I want to emphasize that. I'm going to talk about the features that might help you distinguish MS from Devic's disease. We're going to talk about how you might distinguish MS from acute disseminated encephalomyelitis, or ADEM. We'll talk about progressive multifocal leukoencephalopathy, and I hope we have time to talk about something about osmotic demyelination. So you want to remember that myelin is kind of like the dielectric that insulates the axons. It allows a much faster conduction time from one end to the other. We want to remember that axons are normally myelinated in the peripheral nervous system by Schwann cells and the central nervous system by oligodendrocytes. These are some of my USIS medical students pretending to be Schwann cells around one axon, and then we have the nodes of Ranvier in between the individual Schwann cells, and 6 or more Schwann cells myelinate a single axon. But in the central nervous system, like Shiva, one oligodendrocyte sends myelin paddles around multiple adjacent axons. In fact, one oligodendrocyte may myelinate up to 50 axons, which means if you have one sick or dead oligodendrocyte, you have a big patch of demyelination. And then that's going to alter the conduction and the functionality of that axon. So this is very important. This is why diseases that affect the oligodendrocytes, demyelinating a peripherally myelinated nerve is going to be so detrimental to the patient. So we're going to talk about inflammatory demyelination primarily, and that's multiple sclerosis and acute disseminated encephalomyelitis. I'm also going to talk about infectious demyelination, and that's primarily progressive multifocal leukoencephalopathy, or PML, and I hope that in the time that I have, we'll be able to talk about osmotic demyelination. So let's talk about multiple sclerosis first. The name tells it all. These patients have multiple episodes. It is not a monophasic disease. They have multiple episodes, and I have this table repeated throughout the talk, and all of these slides should be in the handout on the thumb drive that they gave you. But MS gives you multiphasic clinical presentation. You typically have smaller lesions. If you look at the spinal cord, it typically involves short segments. CSF cells or pleocytosis are relatively uncommon. We always talk about myelin basic protein, which is a nonspecific sign of destruction of the myelin from a variety of causes. And then the characteristic thing we look for is oligoclonal bands when we think the patient has MS. So again, this is the most common demyelinating disease of a previously myelinated brain. It's usually a multiphasic disease. We've all been taught that it's more common in the temperate zones. I contacted my favorite consultant, Dr. Google, and I found out that just like everything else, your microbiome apparently controls whether or not you have multiple sclerosis. So maybe in the future we'll take poop tablets from somebody who doesn't have MS as a way of getting the right bacteria so we don't have MS. There's several different classifications of MS. I think they're clinically important. They're not that important for radiologists, but just as a reminder in a graphic way, the most common is relapsing and remitting MS, where the patient has symptoms and then returns to the baseline. Then there's secondary progressive MS, which is like the first type, except that eventually they get progressively worse and worse without returning to baseline. Then there's progressive relapsing MS, where they never return to the baseline. And then there's primary progressive MS, where they never have any remissions, they just get worse and worse. And this is a graphic way of looking at that clinical terminology that we use. So classic MS was defined by Charcot, more common in women of basically childbearing age. It does shorten the life expectancy in some patients a little bit. The median life expectancy is 7 years shorter than without it. And again, we know epidemiologically it tends to occur with increasing latitude from the equator. So we've all seen these maps of where MS is more prevalent. It seems to spare the tropics. And again, some people have said this sparing of the tropics is actually related to bacteria. So I just want to tell you, it's really important to have a couple of good parasites. Parasites actually modulate the immune system. They downregulate our immune response. We evolved being exposed to parasites, and so without having that effect of parasites downregulating the immune system, we have allergies, we have autoimmune diseases, we have things like multiple sclerosis. Just think about that for a second. I have a colleague who's an MD, PhD microbiologist, and he thinks that we should be taking extracts of parasites that downregulate the immune system. So maybe in the future, it won't be the gut microbiome, it may be something else that we're talking about. So the classic lesion that we have in multiple sclerosis are the periventricular plaques. These are the small oval lesions that are perpendicular to the ventricular system. We commonly use this name, Dawson's fingers, to talk about them. This is my cartoon schematic of what classic MS looks like. The lesions are all typically less than 15 millimeters, and the most characteristic ones are these ones that are oval and perpendicular to the margins of the lateral ventricle. And again, I don't think that Dr. Dawson actually had this radiologic use of his term in mind when he coined the term Dawson's fingers. So this is a classic example of multiple sclerosis here. It's probably the most prototypic one that I could find. Again, we have these small lesions, oval lesions. Just as a reminder, in the real world, you also do get lesions that appear to be a little bit atypical, that are larger and more peripheral. And the sagittal image, the sagittal flare, is very, very useful in identifying this characteristic orientation. And I always remember what typical classic MS looks like when I think about this patient here who came in that had kind of a mohawk with a rainbow effect here. One of his parents was a peacock, so this is the way that he ended up. So we also look for the callosal septal interface, and several other speakers in this course talked about that. So what does the path look like? One of the things that I mentioned in the talk about tuberous sclerosis is that the normal white color of the white matter comes from myelin. So if you lose the myelin, you lose that white color. So if you look at the ventricles here, there's this patch around the ventricles. This is the caudate nucleus, but out here in what should all be white matter, you have these periventricular lesions that have lost their myelin. These are thin. This is kind of like Dawson's fingers. These are Dawson's thumbs over here. And that's due to perivenular demyelination. The inflammatory process comes from cells leaving the vessels and getting into the periventricular spaces. Do pathologists make the diagnosis of multiple sclerosis? Well, number one, they shouldn't get any tissue to make that diagnosis because we shouldn't be biopsying things that are demyelinating disease. And the answer is no. Pathologists do not diagnose the types of demyelination. The only thing a pathologist does is they recognize that you have cellular processes, you have axons and dendrites running through an area that should be blue that doesn't have any myelin. That's all the pathologists ever do. They're not going to tell you what type of demyelinating disease the patient has. Multiple sclerosis can cause permanent damage to the brain, so the patients may or may not be symptomatic for the areas that are permanently damaged, but you can end up having progressive atrophy, thinning of the corpus callosum here, and you end up having, again, not only the hyperintensity in the callosal septal region, but you can also have these black holes. And apparently the lesion burden for the patient, their symptomatology and functionality burden, is directly related to how many of these persistent black holes they have, these hypointense areas on the T1 weighted images. So this directly correlates with the patient's permanent disability in patients who have severe, long-standing multiple sclerosis. So again, this is something that we talk about all the time, black holes. By the way, PBS sent me a news alert that a black hole was discovered yesterday, and hopefully it's going to be sucking in all of our politicians. But anyway, Getting back to this, some of the things that sometimes hear and people try to sort out white matter disease, they talk about the subcortical U fibers. It ends up that most of the white matter diseases that cause demyelination do involve the U fibers. It's the dysmyelinating diseases, the congenital ones, that typically spare the U fibers. And you'll know that from the clinical presentation of the patient. Let me talk about tumefactive demyelination. I have a good friend who's a neuropathologist at Johns Hopkins, and there is a rad path course that we do together, and every time he gets up, he sees me in the audience and he yells at me. He goes, "We should never see histology from tumefactive demyelinating lesions. This is the problem with the radiologist making the incorrect interpretation." And then he proceeds to show a bunch of lesions that were biopsied. So what is tumefactive demyelination? I think we all know from the name, it's descriptive. Tumefactive demyelination is a process whose underlying physiology is demyelination, but it's taking up space. Instead of just being an area of abnormal signal, abnormal attenuation, abnormal enhancement, it's a lesion that seems to take up some space, or it's too big or too funny looking to be put into the basket of those small ovoid lesions that we talked about. Why does it get to be tumefactive when it does have mass effect? Well, apparently in the process of the inflammation, there is an influx of reactive astrocytes, and those reactive astrocytes can even simulate on spectroscopy some of the things that we see associated with a neoplasm, including that you have an increase in the choline peak and you drop the NAA peak. So these lesions are classically described as being relatively large. They have disproportionately less mass effect than you would expect for the size if it was a met or an abscess. They may have vasogenic edema, but they usually don't. But this is kind of the trick that we've been using for quite some time to diagnose tumefactive demyelinating lesions, or TDL. And that is that they tend not to have a complete ring of enhancement. They have an open ring of enhancement, or a horseshoe sign. If you're doing a lot of susceptibility imaging, you may notice in a tumefactive demyelinating lesion that you see flow voids, normal vessels running all the way through the lesion, which would not happen if it was an abscess or a neoplasm. So that can be very, very helpful. And again, they can have a neoplastic type spectrum. They tend to have reduced cerebral blood flow if you're doing that. So this is the first case I ever saw. This is my index case. Let me take you on the journey of how I learned about tumefactive demyelination a long, long time ago. I'm with my fellow. My fellow shows me this case. He says, "What do you think it is, Jim?" And I said, "It's a solitary deep lesion in an adult patient with irregular rim enhancement. It's going to be a glioblastoma multiforme." And he looks at me and he says, "What else could it be?" That's the thing you never want to hear, is when someone says, "What else could it be?" So I'm looking at it and I'm going like, well, it's an adult patient, cerebral hemisphere, an irregularly heterogeneous ring enhancing lesion. And he looks at me and he goes, "Jim, what's missing?" And I said, "Oh, if he has a ring-enhancing lesion, why does he not have any surrounding vasogenic edema? If you thought it was an abscess or you thought it was a GBM, both of those would have surrounding vasogenic edema. If you thought it was a necrotic metastasis, that would have surrounding vasogenic edema." And so the first case that I ever saw, this one right here, the thing that clicked in my mind was, I have enhancement, but I don't have surrounding vasogenic edema. Now, a better perspective is the one that we learned from a couple of papers that appeared in the neurology literature, and that's what they call the open ring sign. And that was published by Joe Masdu in Journal of Neuroimaging and then in Neurology. When you have a tumefactive demyelinating lesion, you have an incomplete rim of enhancement around the outside. And that's the classic sign that people look for, is this horseshoe or open ring pattern of enhancement. But I just want to call your attention to the fact that you have these ring-enhancing lesions, and it is an open ring of enhancement. But the other thing that you should notice is that the signal abnormality on the T2 and the flare ends at the edge of the contrast enhancement. There's no perilesional vasogenic edema. So the missing ingredient for this to be an abscess or a neoplasm primary or secondary is that it doesn't have surrounding vasogenic edema. It's not just the open ring. It's the combination of the open ring, the lack of mass effect, and the fact that you don't have surrounding vasogenic edema. So this is, I think, a very useful feature to avoid getting a biopsy of a tumefactive demyelinating lesion. The edge of the abnormality is the edge of the enhancement that you see. So again, we have a couple of other lesions here, relatively large, almost no mass effect for the size of a lesion, and an incomplete rim of enhancement around the outside. They typically are going to enhance for several weeks, maybe a couple of months. When we have ring-enhancing lesions, if you have an abscess or you have a neoplasm, you expect to have extensive surrounding vasogenic edema. If you have this open ring sign, you have to think about the possibility of tumefactive demyelination. So again, when you're looking at these lesions, you want to remember not just the incomplete rim of enhancement, but the lack of the surrounding vasogenic edema. Very, very useful. A couple of very, very wild cases here of surrounding enhancement. Now, something that occurs very rarely as part of demyelination and may occur more often with ADEM is hemorrhagic encephalomyelitis or Hurst phenomenon. And these patients actually have such a rip-roaring inflammatory reaction that they have frank and gross hemorrhage into the cerebral hemisphere, which we can see here on the CT and with T2 shortening on the MR scan. And this, unfortunately, is usually the end stage of this flavor of demyelinating disease. I'm going to skip transverse myelitis in the interest of time. Has anyone here seen a case of Balo's concentric sclerosis? Anybody ever seen that? This is sort of an Aunt Minnie, thank you. This is sort of an Aunt Minnie diagnosis. They say that a radiologist can only see what she or he has seen before. So I wanted to show you a case of it. And it's an Aunt Minnie diagnosis because it has this very characteristic appearance of alternating bands of demyelination and remyelination. That's the hypothesis from the pathologist. So when you see something like this, and for the size of this abnormality, relatively little mass effect, you should think that this is, again, another variant of inflammatory demyelination called Balo's concentric sclerosis. So that's very, very important. Now, neuromyelitis optica, or DeVick's disease. The descriptive name tells you that these patients have a paucity of brain findings. Most of the findings involve the spinal cord and the optic nerves. And it may be multiphasic. It may be recurrent in these patients. And again, eponymically, it's called DeVick's disease. So NMO is also a potentially recurrent multiphasic relapsing disease. The singular hallmark appears to be the involvement of the optic nerve and the spinal cord, not always at exactly the same time. But the critical thing for this disease is that there's a very specific IgG against aquaporin 4 that you can find in the CSF. It's extremely specific. The sensitivity is more than 50%, but people argue about the relative sensitivity at any point in time. So if you get a lumbar puncture in these patients and they have this very specific NMO protein, if they have this IgG to aquaporin 4, then you've made the diagnosis. And people say that the prognosis and the therapy are slightly different than for MS. So these patients have spinal cord and optic nerve involvement. They have relative sparing of the brain, but they may have involvement of the brain, which can confuse things clinically as well as on imaging. And again, the antibody is directed against one of the water channels in the cells, aquaporin 4. So again, you expect to see enhancement in the optic nerve, and as Blake told us, optic nerve enhancement is always abnormal. It's either inflammatory and itis, or it's going to be expansive. It's a neoplasm. It's going to be an OMA. And again, you have unilateral optic nerve enhancement here without enlargement. That's classic for what happens with NMO, and sometimes MS will also involve the optic nerve. We know what optic nerve gliomas look like. This is the same example I showed you earlier in the lecture on neurofibromatosis type 1. So just to remind you. So we typically have involvement, again, of the spinal cord and the optic nerve at the same time when a patient has NMO. So this is a different patient. So we have optic nerve enhancement on the right, an abnormal signal in the medulla going into the cervical spinal cord. And again, this is a proven case of DeVick's disease or aquaporin 4 autoimmune IgG. So this is the key finding for the clinicians. This is the key finding if we do immunostaining on pathology or if we look for that specific component in cerebral spinal fluid. The most interesting thing I have ever learned about DeVick's disease is some of the patients present with intractable hiccups. Isn't that a great thing to put in your back pocket and carry with you? You know, you're talking to the clinicians and they say, you know, it's really weird. I think the patient has MS. What did the patient present with? Well, the guy presented with hiccups, you know, and we tried everything to get rid of the hiccups. We had him breathe in a paper bag, drink a glass of water. We gave him some Thorazine. Nothing got rid of the hiccups. This is something that's a little bit unique for neuromyelitis optica. And again, that's something to put in your back pocket. So the critical thing for diagnosing NMO is to be able to identify in CSF the NMO protein. How many of you have to do LPs for the clinicians in your place? Isn't that a travesty? Isn't that a total travesty? They should be able to do the LPs themselves. LP is not an exotic thing. I did a medical internship, and when I was an intern, if the patient had an altered mental status and a fever, they had to have an LP. You couldn't talk your way out of it. You weren't going to do it tomorrow. It was going to happen the same day. And I was in a big city hospital where the most common cause of a fever and an altered mental status was delirium tremens. I did so many LPs on alcoholics, and they never showed anything. But we didn't have a choice. So when I finished my internship, I had done about 75 lumbar punctures. When I became a radiology resident, I would get these NIMNOs asking me to do an LP under fluoro. And I'm going like, did you try? Well, the patient looks heavy. Well, I tried once and I didn't get anywhere. And what I would do, honestly, is I would try to do the LP on the stretcher in the hallway without fluoro. And if I could do that, I would shame them. If I did that, I would write a note saying lumbar puncture done without fluoro. Why should I irradiate the patient and myself to do an LP under fluoro if you can actually do it by just careful positioning of the patient? I'm not telling you guys what to do. I'm just saying that people are now phobic of doing LPs, and the fewer you do, the worse you are at it. And the worse you are, the worse you train people, and then nobody knows how to do an LP anymore except for radiologists. So what is ADEM? The characteristic of acute disseminated encephalomyelitis is that it's supposed to be a monophasic disease. And in the vast majority of patients, it will be a monophasic disease. And there is a little wiggle room here. Some patients, a small percentage, can have a second symptomatic episode within 6 months of the original presentation. But beyond 6 months, if they have another episode, they're no longer considered to be ADEM. They get thrown into atypical multiple sclerosis. The characteristic for this disease is very common involvement of the gray matter and lesions that tend not to be completely periventricular and lesions that tend to be larger and rounder. Those are characteristics that are very helpful when the Yosemite Sam questions come up later on at the end of the talk. So when you look at ADEM, you typically have younger patients. This is a disease of children. There is almost always an immune inciting event, which may be an upper respiratory infection, it may be a gastrointestinal infection, it may be the booster shot or second immunization that they get. And so something is causing the patient to have a reaction to their own myelin. There's a variety of different explanations for that. So the only vaccine that's been proven to be associated with ADEM is the simple rabies vaccine, which is cultured in rat nervous tissue. But all of these have been reported. All of the standard vaccinations for childhood diseases have been associated, but not necessarily proven to cause ADEM. And the Gardasil vaccine is also associated with ADEM. Don't raise your hands if you have children that have gotten the Gardasil vaccine, but we now know that 90% of head and neck cancers are associated with HPV virus, and we know that if we vaccinate children, we won't have any business for the head and neck radiologists going forward because all those tumors, well, maybe some will stay, but that's very important. So this is something just to keep in mind if someone says, by the way, the child had their third Gardasil vaccination. So cartoon-like, we have larger lesions. They tend to be more peripheral. They tend to be a little bit geographic. They involve the gray matter of the thalamus here as well as involving the white matter. Again, rounded lesions, more peripheral. They can enhance like any inflammatory demyelinating disease. They can involve the gray matter of the basal ganglia and the thalamus. Very important to keep in mind. And again, the classic ADEM is going to be in a young patient, but we see lots of adult patients who are on immune modulating therapy presenting with ADEM. So larger lesions, rounded lesions, lesions that are not oval and perpendicular to the white matter, we're thinking about ADEM, and they can have very, very angry looking, disturbing patterns of ring enhancement. But if it's clinically consistent by the age and by the presentation after an immune stimulating event, think about ADEM. And again, when you talk to the pathologist, all they see are denuded cellular processes. They see axons and dendrites without any myelin, and then they see perivenular small round blue cells. They see a white cell infiltrate around the vessels. So again, this is the classic presentation for ADEM. I want to talk now about progressive multifocal leukoencephalopathy. Let me just ask a question here. How many in this room have been infected by the virus that causes PML? Just a show of hands. Everyone should raise your hand. We have all been exposed and we have all been infected by the virus that causes PML. And if you have a normal, intact immune system, you don't have the disease that we call progressive multifocal leukoencephalopathy. It's caused by a virus that's named after the patient. It's not a HIPAA violation to mention his name. John Cunningham was a patient who had lymphoma and died from some bizarre white matter disease while he was under chemotherapy. But this is something that infects lots and lots of humans. Lots of us are carrying around the antibodies against PML. It's when you have active viral replication that you begin to show the PML antigen in your serum and CSF, and that typically is associated with immune modulation therapy or immune modulating diseases like HIV/AIDS. And so the explosion of PML occurred when we had a large population of patients who were immune suppressed from having been infected with the HIV virus. So again, this disease is a virus that directly replicates in oligodendrocytes and kills the oligodendrocytes. Lots of the CNS viruses that cause encephalopathy infect the neurons. This disease affects the oligodendrocytes. So you have lesions that are very, very peripheral. They're geographic. They come right up to the gray matter and then they stop. They may involve the corpus callosum, which is what you're seeing here. But this is the classic pattern for PML, and you have a history that the patient has some kind of immune modulation or immune suppression. Classically, there is no enhancement. Occasionally, there's faint enhancement, but typically, there's no mass effect. And these lesions can involve the white matter anywhere. The largest white matter in the posterior fossa is the middle cerebellar peduncle or the brachium pontus. And you can have an abnormal MR spectrum because of the inflammatory reaction that occurs in PML. So that's something else to keep in mind. But the classic appearance is a very large geographic lesion that comes right up to the gray matter and stops, has no enhancement, and there's virtually no mass effect here. And if you look at this beautiful coronal image, you have all of this abnormally discolored white matter that is caving away from the edge of the cut slice. It comes right up to the gray matter, and then it stops. Now, the last thing I want to talk about in the last 3 minutes is osmotic myelinolysis, what we used to call central pontine myelinolysis. You know who invented this disease? Doctors invented this disease. This is a completely iatrogenic disease. It did not exist until we started treating alcoholic patients who had hyponatremia. So we used to call it CPM because we know that about 60% of patients, 66% of patients in some series, about 2/3, have demyelination involving the central pons. It's associated with alcoholism, malnutrition, and with physicians. It doesn't occur in untreated patients. It only occurs in patients who have hyponatremia that's treated by giving hypertonic saline. It's selective damage to the oligodendrocytes, over rapid correction of hyponatremia, and I will talk about this a little bit more tomorrow when we talk about the found down patients. So it's very important to realize that this is completely related to things that doctors do to patients. So these patients typically get worse a couple of days after having correction of hyponatremia. They get a bulbar palsy, pseudobulbar palsy, and spastic paraparesis. But the classic presentation is going to be a central lesion within the pons with a rim of a normal signal around the outside. So if we look at this patient, there's a central lesion in the pons here. We can also see extrapontine myelinolysis involving other gray matter areas. We look here, and again, the central portion of the pons has abnormal signal, but a peripheral rim of normal brain tissue exists around the outside. It can have restricted diffusion. It can be dark on the ADC map. And again, pathologically, it's a loss of myelin in this central portion of the pons. This is not how we like to see our patients, but all of this discoloration here in the central pons is because of osmotic demyelination. So we had a chance to talk about a lot of these things. Let me see if I can summarize them. Has anybody here been in the military? I know there's a couple of people here. So what they told us when I was working for the Department of the Army was that you tell people what you're going to tell them. You tell them what you told them at the end. So let's see what we talked about. We talked about tumefactive demyelination, how to recognize that. We talked about how Debic's disease is typically going to be relatively sparing of the brain. We talked about how ADEM gives us larger lesions, more peripheral. Every one of us has been exposed to PML, but it's immune suppression that's important for the demyelination. So cartoon of MS here, small ovoid lesions. Remember the guy with the rainbow mohawk. the Dawson's fingers. They are perpendicular to the edge of the ventricle and relatively small in diameter. Tumefactive demyelination, the open ring of enhancement. The first one I saw, no surrounding vasogenic edema. A couple of other examples showing the same kind of open ring or horseshoe of enhancement, and again, no surrounding vasogenic edema. ADEM, we want to remember the larger rounded lesions that aren't touching the ventricle, that are more peripheral, and again, they may involve the gray matter in the brainstem and the thalamus. We showed you one complication of any kind of demyelination, which is that hemorrhagic phenomenon or Hurst disease. And then we talked about PML with peripheral lesions, and we talked about central pontine myelinolysis or osmotic myelinolysis. So that's it for kind of a brief run-through of a bunch of different patterns of demyelination, clinical and radiologic, and I hope that will help you out.